My patient was apparently well 6 months back when she developed swelling on the right side of neck, which was insidious in onset, small, approximately 2 into 2 centimeter to begin with, and has now progressed to the present size of 6 into 6 centimeter. It is not associated with pain or evening rise of temperature or night sweats, not associated with any form of discharge from the swelling. There is no history of loss of weight or loss of appetite. There is no history of swellings anywhere else in the body. No history of any ulcer or lesion in the oral cavity. No history of difficulty in deglutition, globus sensation, foreign body sensation, or pain in the ear. No history of hoarseness, throat pain, or repeated throat clearing. No history of nasal congestion, epistaxis, nasal discharge, or swelling around the face. There is no history in difficulty in breathing, cough, or hemoptysis, no history of TB or TB contact, and there is no history of high risk sexual behavior. Past history, my patient has no history of any other previous medical or surgical illnesses. She's a vegetarian by diet. She doesn't consume alcohol or tobacco in any form. There is no history of any cancer or cancer related deaths or any TB contact in the family. My patient attained menarche at 14 years of age. Since then, she's had regular periods which are lasting 28 days. She bleeds for 4 days a week, 4 days in a cycle. She's P2, L2, A0. All children are alive and healthy. To summarize my history, my patient is a 45-year-old lady with swelling in the right side of neck for last 6 months, which is insidious in onset, gradually increasing in size with no constitutional symptoms or no other swellings anywhere else in the body.
Did you forget telling any history in specific to a neck swelling? Okay, swelling in the neck. Okay. So, any specific history you want to? You told about tuberculosis.
Yeah.
You told about any fever or any inflammatory this one.
Yes.
Okay. Anything else? What can present as occult swellings in the neck?
Thyroid swellings can present as occult swellings.
History of radiation exposure?
Yes.
That's fine. You forgot to tell. So, did you tell about fever?
Yes, ma'am.
You told me.
Yes.
So, more specifically in this case, when no history of noticing any other swellings anywhere else, you can still specify it whether it is in the upper part of the neck or in the lower part of the neck. Just to give a clue. Okay. So, it is different, for the swellings which can present as upper cervical lymph nodes or lower cervical lymph nodes.
Yes.
Right?
Yes.
So, okay. So, from your history, what is your what do you think it is?
Ma'am, directly we can say that patient presented with the complaint of swelling in upper part or lower part of neck like that.
Yeah. If it is no other swellings anywhere else in the body, just to guide at the end of your history. So to get a suppose whatever history you are telling, examiner is listening and he has to have some diagnosis in mind. Okay. Yes. So X-ray neck cannot be taken more specifically if you tell upper part of the neck or lower part of the neck. Okay. So give a clue, that's it. Okay. If it is a carcinoma unknown primary swelling that you are thinking in mind. Okay. So yeah, what are your differential diagnosis? Let it be that you have not told it is upper part or lower part. Okay. What are the differential diagnosis in your mind?
Ma'am, my differential diagnosis just based on the history are an enlarged lymph node which could be inflammatory secondary to tuberculosis or a malignant secondary to malignancy which can be unknown primary. It can be a brachial cyst, or it can be a thyroid swelling which is arising from the lateral part.
So, what are your like features supporting malignancy in your history?
Ma'am, she is a 45-year-old lady who has a swelling which has progressed to more than double the size in 6 months duration, and it is a painless swelling, ma'am.
Okay. Can it be still inflammatory? I mean, can it be still tuberculosis?
Yes, ma'am, it can still be tuberculosis.
So even any tuberculosis swellings in the neck also may not be associated with any signs of inflammation.
Yes.
Yeah, unless it presents with a discharging sinus or not, but it can still be tuberculosis.
Yes, ma'am.
There is nothing like very specific in your history that points directly towards malignancy. There is
Yes.
history of loss of appetite, no oral swellings. Okay, if you
Yes.
consider no difficulty in breathing, if it is a lower neck swelling, you are thinking you're not having any other swellings in the neck or any pressure symptoms to point to thyroid, right?
Yes, ma'am.
So it can still be inflammatory. So you have to keep your differential diagnosis broad. What did you tell brachial cyst?
Yes, ma'am. Although this is not the age at which this presents.
So unlikely.
Yes, ma'am.
So
Or thyroid swelling.
it can be still any other soft tissue tumor in the neck.
Can be a carotid body tumor or a paraganglioma, ma'am.
It can be a sternobastroid tumor. It can be from the vessel sheath tumor, some cavernomas. Okay.
Yes.
So soft tissue tumor, it can be from the blood vessel, from the nerve. Schwannomas can be there. Okay. So it can be even that kind of tumors. Okay. Primarily in the neck, arising from the neck.
Yes.
It can be an inflammatory swelling. Okay. Lastly, it can be a metastatic swelling. Okay.
Okay.
From your history, this should be a order.
Okay.
And why did you ask? Okay, almost always like you have asked for nasal congestion, epistaxis, nasal discharge. Why did you ask?
Ma'am, to rule out any nasopharyngeal primary.
Okay. So what are the other features that nasopharyngeal primary can present with? Where all it can spread?
It can have.
In other words, is a nasopharyngeal primary more presenting with an occult lymph node metastasis or a hypopharyngeal primary?
A hypopharyngeal primary, ma'am.
For hypopharynx, more common pyriform fossa presents with an occult. It is the maximum. In case of, if you consider head neck tumors, okay, it is the highest tumor that presents with occult lymph nodal metastasis. Okay. So, did you ask for change in voice?
Yes, ma'am.
Okay. What did you ask? Why globus sensation, pain in the ear?
Ma'am, to rule any form of oropharyngeal symptoms.
So you have asked symptoms pertaining to oral cavity, oropharynx, nasopharynx, hypopharynx.
Yes.
Right?
Yes, ma'am.
About head and neck, and you have asked about something related to thyroid. Did you ask about B symptoms?
Yes, ma'am. Pain, evening rise of temperature, night sweats. I did not write, but I mentioned, ma'am.
Yeah, but you should mention. Okay, lymphoma is one of the second most common. No, after TB.
Yes.
It is lymphoma, then otherwise metastasis. Okay.
Yes.
So you should specifically mention about any other B symptoms like loss of weight, night sweats, okay, like that. So that gives a clue that you are thinking in that terms, okay. So fever can be there, loss of weight can be there, even in metastasis, okay.
Yes.
Lymphoma specifically will have any B symptoms, okay. So yeah, why high risk behavior?
Ma'am, to rule out any form, ma'am, if it's a oropharyngeal primary or high-risk sexual behavior will indicate me that it can be a P16 positive.
Okay. Any other things did you forget? Like you have asked pertaining to head neck. Something else you forgot. Did you ask about any scalp lesions?
Ma'am, in the past history, the patient has not had any other intervention pertaining to any.
What about intervention? Any lesion in the scalp? No, not necessarily a tumor. Okay. So
Yes.
might lead to any cervical lymphadenopathy. More commonly pre-auricular, occipital.
Yes.
Okay. But we still don't know which group you are talking about. Posterior cervical lymph nodes can still be involved. Okay. So that
Yes.
is one subsite you have forgotten. Any eye lesions also can lead to. Okay. You have asked about nose. So eye also can be. Okay. All the facial anything might lead to cervical lymphadenopathy. Okay.
Okay.
Anything else? So thyroid. Next, what did you ask? What symptom? What systems were in your mind?
Ma'am, swellings anywhere else in the body?
That is like okay. That is in terms of TB or lymphomas you are thinking. Okay. Or multiple metastasis. Okay. Next.
Ma'am, if it's a lower neck swelling, then a breast lump or any other.
Did you
Yes.
mention no history of noticing any swellings in the breast? Okay. No history suggestive of any hemoptysis, chest pain. Okay.
Yes.
So lung is other thing that is very common to present with cervical lymph nodal metastasis. Okay. So
Ma'am, GI symptoms should we ask or not? GI?
yeah, GI symptoms you should ask. So I'm going in order. That is what head and neck. Then chest.
Since I didn't write the location of my patient's tumor, but just in case if it is a level 2 or a level 3 lymph node, should we still ask for GI symptoms in the history, or should it only be restricted to a level 4 lymph node?
No, sometimes patient notices swelling which is there in that level, but on your examination you still can find some other lymph node. You can find supraclavicular which they may not have noticed.
Okay.
Right. So you have to cover all the systems. In history, don't skip. Okay. Because it's not been sure that is the only swelling. Patient might have noticed only one swelling. Okay.
Yes.
But there might be multiple swellings, right?
Yes.
So you have to ask all the symptoms. Okay. Even you have to ask pertaining to lungs. You have to ask pertaining to GI, upper GI. Okay.
Yes.
Then you have to ask pertaining to lower GI symptoms. Okay. Any bleeding or all this from starting from head to toe, even in the if there is any swelling in the groin or any other lesions anywhere in the extremities. Okay. So melanoma can also present, right?
Yes.
So
Bone pain.
yeah,
Bone
both
pain.
extremities. That's what I'm telling. Soft tissues and extremities include soft tissues and bone pains, both. Okay. So from head to toe, all symptoms have to be asked for. Okay.
Yes.
Even if you specify, your specification will be related to your differential diagnosis in order, but not to the history. Okay.
Yes.
Yeah. Right. So move on.
Should I go to the examination now?
Ma'am, hello.
Tell.
Ma'am, in this, she has mentioned detailed history about the menstruation and all that. Should we mention like that? Because the relation with the... Hello?
He has to mention. So personal history should include menstruation. Okay. So we don't know. So sometimes cervical cancer can present with cervical lymphadenopathy, cervix cancer. Okay. Not necessarily like it's only inguinal lymph nodes. I have seen one cancer, cervix cancer with supraclavicular lymph node. So in advanced stages, it still can spread to the cervical lymph nodes. So she is right, and as a part of completion also she has to mention it being a female patient. Okay. So yeah.
Okay. Ma'am, the examination. I examined my patient in a well-lit room with informed consent, with adequate exposure in presence of an attendant. My patient was conscious, alert, and cooperative, well-oriented to time-place person, and she was moderately built, well-nourished, with no pallor, icterus, clubbing, cyanosis, or dependent edema. Her vitals were normal. There was no supraclavicular fullness. This is the photograph of my patient, ma'am.
We are not able to see, ma'am. Yeah. Okay.
On inspection, I noticed a 5 into 6 centimeter swelling on the right side of neck in level 3. In the level of in the area of level 3 lymph node, which was globular in shape, but did not move on deglutition, was having overlying discoloration and shiny skin, with impending fungation at the inferior portion of the swelling, with no discharge. There were no other visible swellings in the neck. This swelling was not pulsatile on inspection, and there were no other visible pulsations in the neck. There were no other scar signs of fistula. I examined the scalp and other regions of the head and neck. There were no abnormal lesions or hyperpigmentation which was seen. Ma'am, oral cavity and oropharynx I have mentioned separately as well. On palpation, the temperature of the overlying skin was normal with no tenderness. I confirmed my findings of inspection on palpation. There was a 5.5 into 6 centimeter swelling on the right lateral region of neck corresponding to level 3. It was globular in shape, irregular surface, firm to hard in consistency, with palpable medial, lateral, superior, and inferior margins. Deep margin was not palpable. Overlying skin was not pinchable. The swelling was not pulsatile, non-fluctuant, with impending fungation, and there was it was fixed to the underlying structures. There were no other palpable swellings in the neck or in the supraclavicular region. The thyroid was not palpable. Bilateral carotid pulsations were palpable in their normal position. Examined the oral cavity and the oropharynx. The facial symmetry was normal. Mouth opening was 5 centimeter inter-incisor distance. Tongue protrusion was normal. The tongue movements were also normal. The orodental hygiene was fair. No halitosis, no abnormal lesion or ulceration in the buccal mucosa, RMT, floor of mouth, gingiva, or base of tongue. On inspection and palpation of the oropharynx, bilateral tonsillar pillars, palatine tonsil, soft palate, and posterior pharyngeal wall was normal. Cranial nerve examination 7 to 12 was normal. On Hopkins examination, the base of tongue, vallicula, arytenoids, aryepiglottic fold, epiglottis, false and true vocal cord, and the visualized part of the piriform fossa showed no lesion. The chink was adequate. Nasal endoscopy, bilateral nasal cavity, floor, the inferior and middle the terminates were normal. There was no growth or abnormal mucosa. Rest of the system examination, including bilateral breast and axillary examination, abdominal examination, respiratory, inguinal region examination, cardiovascular and CNS examination were normal. We did a core biopsy and FNSC for this patient. The core biopsy showed metastatic squamous cell carcinoma, which was HPV negative, and further doing an EBV, the EBV was also negative.
Okay. So, do you know examination of all cranial nerves?
Yes.
Tell me, how did you examine 7?
Ma'am, 7th, the facial nerve examination, ma'am, we start from the sensory.
First of all, facial nerve, sensory, motor, or mixed?
Ma'am, the sensory, we'll start from the anterior part of the tongue, the taste sensation. We'll ask the patient to, we'll keep the taste, we'll keep a sugar and salt solution, and we'll ask the patient on both sides of the tongue about the taste sensation.
So where do you keep sugar? Where do you keep salt? this at the tip what it is, at the like lateral borders what it is, at the posteriormost tongue what it is, sensation.
Ma'am, we'll ask, since you're asking for the facial nerve, anterior 2/3 of the tongue, ma'am, I'll ask him.
No, yeah, see, that's why I'm telling. So before you tell everything is normal, be very careful, because examiners know that you will not be provided everything. Okay.
Ma'am, that actually I wanted to ask this also, since everywhere in the carcinoma unknown primary it was written that we have to examine the cranial nerves. Do we have to, ma'am?
You have to tell that I would like to examine the cranial nerves, provided I have all the facilities to examine it. Okay, but you will not be getting all salt solutions, taste for bitter, sour, and all those things. Okay, so don't commit yourself to the extent possible. Whatever I have seen for motor, this one I could see known deficits. That like that you can tell, but don't commit to the statement that everything is normal. Okay, and they will ask again. They'll ask what is the ganglion, track the facial nerve. So be careful when you tell that statement. Okay. So if you know everything, either you know everything and you commit and tell that to the extent whatever I could examine, I have examined, sir. Okay, or ma'am. So, but you should be doubly sure. Okay, we are not very much used to do all those examinations, right? So we will fumble. So, by the way, it is at the tip of tongue. It is salt. Okay, so the posterior most part is salt. Okay, and sorry, at the tip of tongue it is sweet, and at the lateral borders it is salty, and at the posterior most it is sour. Okay, there is different areas perception for different tastes. Okay, so I'll send you that. Okay.
Yes.
Then, eighth, you have to again do
the tuning fork tests, ma'am.
You have to do. Okay.
Yes.
So be careful, ma. Ninth is okay. Gag reflex.
Yes, ma'am.
Ninth and 10th is fine. Okay.
Yes.
7th again shrugging
of the throat.
Yeah. So 12th is tongue movements.
Movements.
Right. But if you are telling that statement, you should be well aware of what at least basic is. Okay. So
can we skip this, ma'am, just in case?
You don't skip. See, cranial nerves have to be examined, but you tell I would like to examine the cranial nerves, sir, but I did not have anything specific for that. Just be prepared for the question. How do you examine means to tell. Okay.
Okay, ma'am.
Okay. Right. So, okay, leave. You have done a biopsy. I want to go from the first. So, how do you approach a case like this?
Ma'am, first of all, we look at.
So, ma'am, PE, PV, PR is to be done, or we can just.
No, everything you have to do. Per abdomen, per vaginal, per rectal, everything has to be done. Okay, all system. Okay, respiratory also. All like you have to see if there are any grafts or there is any air entry is decreased. Okay, lung is more common, no? So any effusion is there. All systems have to be examined. Okay.
Ma'am, even in a level 3 lymph node, we have to do PV and PR.
You should do examination and history wise. Don't skip anything. When you are asked differential diagnosis, I have not felt anything, but still they can be picked up on scan, right?
Yes.
So you are seeing something, but on scan might tell something which is less than 1 centimeters, which you were not able to feel. Okay. Yes. So don't skip anything in examination and history. You should be very meticulous in doing an examination for CUP. Okay.
Yes.
They will, based on your examination and history, what you take, they will know what you are thinking in terms of. Okay. So right. So tell me, how do you proceed when you get a case like this? What do you want to do?
Ma'am, first of all, now that we've done clinical examination and office examination the Hopkins and the nasal endoscopies we've done, and we could not find a primary. Now,
What is pan endoscopy?
sorry,
Though that term is not used now, what is pan endoscopy?
ma'am, pan endoscopy is doing upper GI endoscopy, laryngoscopy, and nasal endoscopy.
Endoscopy, correct? Then?
Nasopharyngoscopy, bronchoscopy,
Yeah,
endoscopy. Endoscopy.
Yeah. Nasopharyngoscopy, upper GI endoscopy, and bronchoscopy. Okay.
Yes.
Yeah. Then, tell me. So, what do you want to do the next?
Consistency, not moving with deglutition, not
Schwannoma.
It can be, but biopsy will only tell.
So, it can be primary. Okay. So,
Okay.
from your examination findings, it can still be a primary. Okay.
Now, ma'am, as it is in level 3, it can be CBT. So we should do imaging first or biopsy first. Like if it is vascular, if we are going to get hemorrhage or so.
Yeah.
Maybe we
vascular, it should
पर
be
pulsatile नहीं है.
pulsatile.
No, but CBT is not that pulsatile generally, na. CBT or paraganglioma.
So, basically,
Paraganglioma will be mobile in side to side direction. This is not mobile.
so one thing you can do, it's like you tell, as an extension of my clinical examination, I would like to do a bedside ultrasound. Okay.
Okay.
So that will give me a clue from where it is arising. Okay. So then, based on this level of lymphadenopathy, my suspicion of it being a metastasis or it being a primary is this and this. Okay. So what are your differential diagnoses in this level?
In this level, ma'am, it can be a lymph node, metastatic lymph node, or it can be a schwannoma or a carotid body tumor. However, it is supposed to be side to side mobile. It is not.
Can it be a tuberculosis?
It can be, ma'am.
Okay. Can it be a occult primary from thyroid?
Yes, ma'am. It can be. It can be, ma'am.
It can be. Okay. Don't think only that other things it is metastasizing. So think in neck only. So then, can it be something like sarcoidosis?
Yes, ma'am. Lymph node secondary to any inflammation or malignancy, ma'am. It can be.
Or primary from the neck itself. Okay. Schwannoma, sarcomas. Okay.
Yes, ma'am.
All this can be a possibilities. Okay. It can be a lymphoma. Still, lymphomas you may not feel all the lymph nodes, but they might have been enlarged on the scan.
Yes.
Okay. So still it can be all the differential diagnosis, all the possible. So from level 3, so what are primaries if you are suspecting it to be metastatic?
Ma'am, it can be a primary from the oral cavity, from the oropharynx, from the hypopharynx, or larynx.
Okay,
or
one second.
thyroid.
So it's a level 3 lymph node. Okay.
Yes.
So be more specific in telling. Okay. If it is from the lip,
Yes.
so lip range to which lymph nodes more commonly?
Level 1 and level 1B and 2, ma'am.
1B. 1B. So it can be melanoma, which is hidden. Okay. So think broad. Okay. Mucosal melanomas may not be noticed. Okay. So then, Then from buccal mucosa, what is the most common lymph nodal drainage for buccal mucosa?
Level 2, ma'am.
Okay. Then tongue?
Tongue to level 1B and 2, ma'am.
1B nahi hai. Level 2, 3. Okay. Escape metastasis can be present to level 4 also. Even 5 also can be present in tongue. Okay. So depends on which tongue it is. Okay. So base of tongue? Oropharynx.
Ma'am, it can have retropharyngeal as well as level 2 and 3.
1 second. Just hold on.
ये लेवल 1A किसमें होता है? 1A लिप में नहीं होगा? नहीं, टिप में हो सकता है, टिप ऑफ टंग। लिप में नहीं होगा? लिप भी हो सकता है। मुझे बोलो, परसों क्लास दिया था
लिप
मैंने,
में
वो
होगा ना, लिप में होगा।
परसों क्लास में बोला था ना, बकल म्यूकोजा बायोप्सी पहले करना है, सीटी पहले करना है?
वो होता है अगर स्मॉल लीजन है that you're doing biopsy will upstage the lesion, then you do CT first. But if it is a large lesion, that if you do a biopsy, it is a very apparent lesion, and doing a biopsy will not cause any upstaging, then you can do a biopsy first. This is what
they didn't agree that then I told biopsy will do first.
So listen, tongue में what in T1 as per NCCN guidelines, in T1 and early to T2, okay, whatever you feel is just a T2 lesion, you can still avoid doing imaging. Okay, you can directly because the instance of occult lymph nodes in stage 1 and 2 is less than how much?
20, less than 20.
Not 20.
10%, less than 10%.
Yeah, there is a table in Davita. Okay, you see that. Okay, incidence of occult lymph nodes in so it is 5 to 10%. That's it. So actually less than 5% if it is T1, purely T1. So NCCN gives that you can still avoid doing an MRI in T1 lesion. Okay, so
USG neck.
you can proceed with the treatment after USG neck. Okay, so you need not do CT or MRI, sorry, in tongue. Okay, so that's why they would have told. But always imaging first, as you told, it's a very small lesion. By your biopsy, you may get some architectural distortions, okay, which might interfere with your imaging. Okay, so that is.
Ma'am, I was pressing buccal mucosa. Madam, it was big lesion, gross. I told I will do biopsy first. But
no, then you should do imaging first. That's what I'm telling you. Yeah, if
even
biopsy first, will interfere with your imaging.
NCCN guidelines says if there is a level 1, 2, 3 involved, so primary after complete evaluation like laryngoscopy, triple panscopy, if there is no residual disease, if you don't find anything, then we can do this thing, ma'am. Biopsy or PET CT. If the level 4 and 5 involved, then we have to do before taking biopsy, we have to do a complete evaluation like CT PET.
Level 4 and 5, more commonly, level 4, okay, is involved with lung and GI. So whenever, that's why your lymph node investigation, is based on the level of the lymph node. Okay, if they are lower level lymph nodes, definitely you have to do a imaging. Okay, because the primary might be something which you will not see. Okay, like lung, GI. Clavicular primary will be there. So something in that case, definitely you have to do an imaging. Okay, in a case where head and neck proper lymph nodes are there, then okay, where do pyriform fossa lymph nodes present? Which level?
Retropharyngeal lymph nodes.
Nasopharynx.
Retropharyngeal followed by level 5, ma'am.
Level 2B. 2B is more common. 2B and 5. Okay, they are more common. Okay, so in your level 3 lymph node, so there are no other symptoms. Okay, I would like to do an ultrasound. Okay, determine where it's originating from. Okay, and then proceed with the preferably a biopsy. Okay, yes. If it is not vascular or anything, preferably biopsy. But had it been a level 4 lymph node or level 5 lymph node, then definitely you are justifying in doing a PET CT. Okay.
Ma'am, one thing, if on clinical examination is highly suspicious of nasopharyngeal, as you said, level 5 or level 2B involved. So in before doing like the ASCO guideline, all that say the complete examination under general anesthesia followed by the a palatal or lingual tonsillectomy? Should we answer in the exam like this if it is a higher lymph node?
No, that's what. If you have not found anything, okay, as a part of treatment, see, there are indications for doing lingual tonsillectomy. There are indications for doing palatal tonsillectomy also.
Yes, ma'am.
If there are indications for doing unilateral, there are indications for doing bilateral also.
Yes.
So,
But that is all if we are finding P16 positive. No, P16 negative, then no.
HPV positive should be there. That's what. If it is
Yes.
oropharynx and you have not found anything, if it is P16 positive, then you are justified in doing lingual tonsillectomy. If it is unilateral, okay. So if it is like something like bilateral lymph nodes are there, okay, but you still did not find primary, then bilateral lingual tonsillectomy. Okay. So fine. So now what will be, you told first I'll do it. Why FNAC, why biopsy?
Ma'am, FNAC is more easily available and it can be done without any special provisions. Biopsy is preferred and is now given in the ASCO recommendations because it helps us to run the tissue for in situ hybridization as well as for the EBV testing, ma'am.
So one thing, so in your whenever you find some carcinoma of unknown primary, so it is like your investigation should not be very exhaustive. Okay, it should be very like you should have something in mind and go accordingly. You cannot do every investigation. Okay, so for you, just by doing FNAC, you might get it is metastatic squamous cell carcinoma.
Yes.
So again, you have to go searching where this squamous cell carcinoma has come from. Okay,
Yes.
so it's better to do a biopsy. That's why ASCO recommends biopsy. Okay, why? Molecular studies, IHC, everything can be done on a biopsy, not an FNAC specimen. Okay,
Yes.
so your determining primary site depends upon where your lymph node is and what is the histological category. Okay, what all can be a suppose leave that you have got a squamous cell carcinoma. So what all pathology can you see?
We can what all subsites can come to level 3, ma'am?
Yeah, what all pathologies you can see, not only level 3, let us discuss in detail. So what all pathologies can you see? If it's a level 3, what? If it is level 4, it is what? What is your
Ma'am, if it is level 2B and level 5, level 2B and 5 are mostly indicative of nasopharyngeal, parotid, and some oropharyngeal primaries. Level 3 and level 2A and level 3 are mostly indicated of oropharyngeal, hypopharyngeal, oral.
I'm asking you pathology, histology.
Ma'am, squamous or adeno or neuroendocrine, melanoma.
I'll
Or
give you some other diagnosis. Poorly differentiated malignancy. Very common, no? To represent it, I mean, you will get it as poorly differentiated malignancy. Right?
yes, ma'am. We can use the IHC for that, ma'am.
That's why you should take a core biopsy. Okay?
Yes.
So, by the way, what is carcinoma of unknown primary? Define it.
Ma'am, carcinoma of unknown primary is a metastasis, a histologically proven metastasis in a cervical lymph node without
No, not cervical lymph node.
In any at any site without the evidence of a primary tumor.
There's a definition. Biopsy proven metastatic cancer in absence of radiographically or pathologically detectable primary tumor, even after adequate diagnostic evaluation. Okay, yes. That is the complete definition. Okay, you cannot detect radiographically or pathologically even after adequate diagnostic evaluation. Okay, but it is proven metastatic cancer. Okay, that is the diagnosis. Okay, so it is diagnosis of exclusion. Okay, before you commit, never tell mine is that carcinoma of unknown primary for evaluation. Okay, don't tell like that. Okay. So it's a swelling.
Madam, the CUP definition applies for lymph node only?
No, it has different sites.
It is like biopsy proven metastatic cancer anywhere. Okay.
But anywhere, it could be a bone also, it could be a node also.
Yeah, it can be node. Generally, it is node. No, it can be a
node, but by definition, could it be like a solitary bone? जैसे patient presented with a pathological fracture, उसके अंदर ये fixation किया bone का और जो material था वो भेजा तो उसमें carcinoma आया. I have not seen such a scenario. I'm just asking.
No, that should be a primary bone tumor involving that bone.
Usually node only. That's all.
Yeah, usually it is node. Okay.
Oh, thank you.
So it's a swelling anywhere. Okay, that is metastatic, proven metastatic cancer. Okay, and with even after adequate diagnostic evaluation. Okay, so yeah, so why are you bothered about what pathology it is, Avneet?
Ma'am, if it is adeno, then my probable sites of primary in cases of a level 2, level 3 will be from a salivary gland.
Okay.
And if it is
level 4?
In cases of level 4, I shall suspect somewhere from the infraclavicular primary, ma'am. Like she's a female, it might come from breast or it might come from a upper GI or lower GI pathology, ma'am.
Lung.
Upper air digestion, ma'am.
And she's a female. Can it be ovary?
Yes, ma'am. Can be ovary.
Can be ovary. Okay. So the general primaries that you look for infraclavicular is liver. Okay. Mediastinal, lung. Okay. Mediastinal or and you will look for any peritoneal cavity like ovary in females or primary peritoneal also. Okay. It can be from any bones. Okay. It can tell present from bony primaries. It can be if it is neuroendocrine tumors. So they will be generally given as poorly differentiated cancers. So that's what I was asking you. If you come, if they comment as poorly differentiated neoplasm, okay?
Yes, ma'am.
Clinical correlation for further evaluation. So like that they'll give. So first thing you have to suspect in those cases is neuroendocrines. Okay.
Yes.
Generally, small cell anaplastics or low-grade neuroendocrine will present like poorly differentiated neoplasms in the neck. Okay.
Yes.
So how do you search for primary? One is histopathology. Then,
ma'am, if we've done the biopsy, now the next thing I will do an imaging. CT, ma'am, the guidelines suggest a CT first, but if the facilities are available.
One more question. You told pan endoscopy if it is level 3 lymph node. If it is level 4 lymph node, any other endoscopies you want to add?
Upper GI scope.
Upper GI is
We were doing anyways.
Thyroid evaluation, ma'am.
No, endoscopy.
Lower GI scopy.
No, lower GI. Colonoscopy. Okay? Colonoscopy.
Ma'am, pan endoscopy includes?
Pan endoscopy, bronchoscopy, nasopharyngoscopy, and upper GI endoscopy.
Ma'am, in level 4
DL scopy and laryngoscopy, nasopharyngoscopy is the different, kya, ma'am?
Same. Only larynx, indirect laryngoscopy is part of it. Okay, bronchoscopy is different.
So, bronchoscopy, laryngoscopy and upper GI scopy comes in pan endoscopy.
No, you are supposed to tell us of nasopharyngoscopy. Okay.
That's why I'm having doubt already. Actually, for upper cervical region and lower cervical region, the scopies are different.
See, up to nasopharynx, okay, you can see there. Okay, and the lower down below the carina, you will see through bronchoscopy. Upper GI endoscopy will also give you a clue about where, which parts.
Upper GI endoscopy में we can see oropharynx, uh, esophagus and stomach.
Oropharynx.
And
Very complicated. So that's why they did not specifically say the laryngoscopy types. Okay.
Ma'am, colonoscopy we're supposed to do only if a level 4 lymph node has come out to be adeno, right?
Yes.
Otherwise, not in case
No, it can be squamous, no? If it's anal region,
Yeah, then it can.
then it can be. So if it is level 4, basically, then you should do. Okay. So yeah, so that's about endoscopy. Histopathology, mein, what all you want to know? You told IHC. Then
IHC, then ma'am, some molecular tests like in situ hybridization for EBV and PCR testing for HPV.
other than that,
IHC testing will do, ma'am. And
suppose it's level 4.
yes, ma'am.
You want to see any cytokeratins.
Yes, ma'am. Also,
साइटोकेराटिन्स ER/PR HER2 भी कर सकते हैं फीमेल पेशेंट पे.
ma'am,
एडिनो आया तो
ma'am, first of all, we'll do TTF and calcitonin and
I think first, madam, depending upon CK7 positive and CK7, CK20, we have to.
So it is lower cervical lymph nodes. Okay. So you can do CK7 and CK20 to differentiate what from what? What is CK20 for?
lung and rectum, lung and colorectal.
GI tract, ma'am. GI tract.
20 is for colorectal, 7 is for ovary.
Lung, na?
No. 7 is not.
CK7 positive, CK20 positive is positive for ovarian,
Ovary.
positive for prostate, is positive for urothelial, and CK7 positive and CK20 negative is for this colorectal. CK7 negative.
I'll tell you easy way to remember it. Okay. So CK20 is positive in what? Colorectal. Okay.
Colorectal.
Yeah. So CK7 is positive in
Lung.
Ovarian.
CK7.
endometrium.
CK7 can be present in lung. Okay, it can be present in genitourinary tract, urothelial tumors. Okay, it can be present in ovary. Genitourinary means ovary, urothelial. Okay, it can be present in HPV, cholangiocarcinoma, pancreatic carcinoma. It can be present. Okay, CK7 positivity. It can be present in endometrium. It can be present in ovary. It can be present in cervix. Okay, if coming to head and neck, it can be present in salivary gland carcinoma. Okay, so these are the things which CK7 will be positive. Both CK7 and CK20 will be positive in HPV and urothelial. Okay, HPV and urothelial. Okay, and both are negative
Hepatocellular. HCC.
and
Cholangio? नहीं, cholangio नहीं, sorry.
Both are negative in head and neck cancers. Both are negative in renal cell.
yes.
Both are negative in
Liver.
hepatocellular.
So they are negative in neuroendocrine tumors. Okay, so
Neuro also.
tumors, these are positive. Okay, and they can be negative in prostate if we consider genitourinary. Okay, so that is easy way to remember. Rest all are positive for CK7. Lung, breast, okay, thyroid, okay, endometrial, salivary, all are positive in CK7. Okay, both are positive in genitourinary HPV. Both are negative in RCC, hepatocellular, head neck. Okay, and neuroendocrine. Okay, and both are only CK20 is positive in colorectal and in Merkel cell. Okay, and both are positive in breast. Okay, right? Okay. Then what else you want to see in immunohistochemistry other than cytokeratin? Cytokeratin says it is which origin?
Epithelial origin.
Epithelial.
So if it is sarcomas.
Vimentin, Desmin, S100.
HMB.
HMB.
HMB45 and S100 are more specific for what?
Melanoma.
And LCA is positive for what?
Sorry, ma'am?
LCA.
What, ma'am?
LCA. Leukocyte.
Lymphoma.
Yes, it is in lymphoma. LCA. Okay. Tell me something. Neuroendocrine carcinoma gives positivity for
Chromogranin.
Inolis.
Synaptophysin chromogranin. Okay.
And NSC, neuron-specific inolis.
Yes, neuron-specific inolis. So apart from this, sarcomas?
Vimentin.
Yes. Okay. And germ cell tumors we discussed last time. So
Yes.
LDL, beta
Alpha-fetoprotein.
एक SALLA4 होता है.
Okay. So these are the most common things that are done. Suppose to tell that it is carcinoma, what should be definitely present?
CK, ma'am. CK positivity.
Cytokeratin positive it should be. Okay. And apart from that?
AE1, AE3 positivity.
Yes. If it is lymphoma?
CD34.
And common leukocyte antigen positivity. Okay.
Yes.
Next. Okay, that is about IHC. Okay, anything else which you want to see in pathology? Okay,
Keratinizing or non-keratinizing, ma'am?
Yeah. Okay, TTF1 is positive in what?
Ma'am, lung.
Thyroid.
Lung and thyroid.
Thyroid.
GCDFP?
Breast.
Mama globulin?
Breast.
Gata also breast.
Calretinine, medullary thyroid cancer.
Medullary.
No. Calcitonin nahi, calretinine.
Calretin breast, madam.
No. Mesothelioma, correct.
Mesothelioma.
Then uroplakin?
Neuro?
Uroplakin?
Urinary bladder.
Urothelial carcinoma. Then CDX2?
Colon.
Stomach, madam.
Basically GI cancer. Okay. Then PSA?
Prostate.
Other than that? What resembles molecular structure of PSA?
Beta HCG.
सबका भाई है ना.
Sorry?
No.
So, thyroglobulin?
TG.
Thyroid cancer, ma'am.
Differentiated thyroid cancer.
Papillary.
Differentiated thyroid cancer.
Yes. And these I think are most of them. Thyroids, okay? Few can present with false positive. Okay.
PAX
So
8.
Then, what about CD45? What is the thing that differentiate B from T cell?
1920.
and 45.
20 and 40.
Which is in B, which is in T?
45 is in B.
D. Okay. CD45?
I'm not aware. C.
Plasma cell.
CD45 is?
CD3 is a pan T cell marker. And CD20 is pan 19 and 20 pan B cell marker.
Correct. Yeah, and CD45 can be present in any lymphoma. Okay. Right. So apart from this Ovary, what you will see? Specifically, if you want to see.
VT1.
PAX 8.
VT1.
WT1.
Backstate VT1.
Okay. And CA?
Mucinous, any kind of mucinous ovary, mucinous
Lung can present. Okay. Any CA19-9?
any hepatobiliary, or also in few ovarian.
Sorry.
Mucinous ovarian.
Yeah, mucinous ovary, lung. Any think of mucinous ovary. Okay. ERPR?
Breast and endometrial and some low grade ovarian.
Okay. Stomach? HER2? Sorry.
HER2, GB, stomach, esophagus, breast.
Yeah. So these are basic things that we look for most commonly. Okay. Okay. Apart from this, what else you want to do? Immunohistochemistry you have done.
Keratinizing or non-keratinizing, I want to see, ma'am.
Okay. Why?
If it is non-keratinizing, it will point more towards an HPV positive pathology.
How are HPV tumors different from non-HPV? Tell 4 points.
HPV positive tumors are seen more in young population, non-smokers, better prognosis, not associated with smoking.
Small primary with a large
Small primary, big.
T size is small, N is high.
So HPV stage is starts from 6.
Yes.
So yeah. So you want to do next will be so we'll move on to molecular. We'll do later. Okay. So tell me what imaging you'll start with.
CT, chest, abdomen, and pelvis. Or if the finances and the facilities are there, then we can go for PET CT also.
Okay. So when is PET more useful? Which level?
Level 4.
Lower level lymph nodes mainly. Okay.
Yes,
large lymph node, bulky lymph nodes, lower level lymph nodes, PET is indicated even in head and neck. Okay. So so lower level lymph. Other than this, if you find lower level lymph nodes, what all other imaging studies you want to do? Level 4.
One is the upper GI and lower GI scopies I want to do, ma'am.
Copy done.
Mammography, ma'am, in this patient.
Mammography, yes. Next. Anything else? So suppose PET is not available. Let us take like that. PET is not available. Then
CT chest and abdomen.
CT we've done.
okay. Suppose there is some lesion in axilla, occult lymph node in axilla.
MRI.
MRI. Okay. So what is I told you 2 indications where role of PET in carcinoma of unknown primary. Can you tell me a little more?
Ma'am, 20% of the cases where the primary is not found, we can find it in PET.
Okay.
Sorry, thank you.
And when you find only that single lymph node, there is no other therapy given prior. Okay, that is the only single lymph node. Okay, and lower level lymph node that will give you more specific information. Okay, yeah. So what about tumor markers? Tell me something about what you will do. Done everything here. Okay? Molecular we'll discuss. because a little more we have, because you've done everything, but still you don't find the primary. That's in how many cases?
2% cases, ma'am.
Malignant 3 to
ज़्यादा
5%.
more than ज़्यादा.
Now, ma'am, they said that the true incidence of carcinoma unknown primary is only in 2%.
1 to 2%.
No. If you do every investigation, endoscopy, imaging, immunohistochemistry, not molecular. That's why I'm telling you now it is era of molecular cytology and molecular analysis. But without that, initially, like how many cases would be like that? That antemortem you will never find.
10.
Ma'am, in head and neck it is roughly around 3 to 5%, ma'am. But overall, I don't know.
Overall,
I don't know.
it was almost 30% prior to molecular era. So that has been reduced now to hardly less than 5% once that molecular analysis has come. Okay. Yeah. So, what molecular analysis you want to do?
I want to do first I want to test for HPV, ma'am. That is through the PCR testing. And if it comes out to be negative, then I want to do in situ hybridization for EBV.
Okay. In your case, suppose it is lower neck primary.
Ma'am, mostly P16 is done for HPV testing is done for level 2 and 3 lymph nodes only, but it can also be done for level 4. But in them, we'll have to see other findings, like if it is keratinizing or non-keratinizing, or
some pan markers were there, which initially we do for all cases to see the origin of the lineage origin. Then that is lymphoma or squamous cell or adeno.
What P63?
Sorry, ma'am.
What is P63 indicating? P63.
P63, ma'am.
P63 is a marker of invasive squamous cell carcinoma.
Ma'am, we can't hear you. There is some noise.
Rakesh, mute yourself. Yeah. P63 is indicator of invasive squamous cell carcinoma. Okay.
Okay.
So P16, apart from P16, anything else you want to do if it is a HPV? Can you do DNA?
Viral load करना पड़ेगा.
Yeah. Can you do DNA analysis?
Yes, ma'am.
So that testing is done. Okay. And what else? Yeah, that is more about. And what molecular methods do you do, like to do the molecular testing?
Ma'am, we can do it either on the immunohistochemistry or we can do it on the PCR.
What are markers that can be found on immunohistochemistry?
Ma'am, P60 on immunohistochemistry, DNA examination on PCR or either fish.
Colorectal में क्या करते हो रे?
MSI.
IHC.
MSI is not on immunohistochemistry.
MMR protein proficiency is seen on IHC, and on NGS we see the MSI testing.
So NGS में you can do MSI. What about test material?
In that also, ma'am, we can do on the tissue we can do P53 and MMR. On poly testing we have to do on the NGS.
Okay, so that's a few methods which you will do for molecular testing. So tell me, like based on your subsite where it is found, like suppose it's cervical or axillary. Okay. So is there any classification to tell prognosticate the patient that you will have better survival with treatment, or you will have poor survival? Is there anything like that?
If diagnosed unknown primary, if it is diagnosed, then it is have a better prognosis, and HPV positive patient have better prognosis.
Also,
When
Smoker?
HPV positive with a smoker is a poor
has a worse
prognosis.
prognosis. If there is a EC, there is a study, ma'am, which says that if it's a P16 positive with no less than 10 pack years of smoking, it has the best prognosis. If it is a P16 positive with more than 10 pack years of smoking, it has a little worse prognosis. But a non-HPV negative with the smoker has the worst kind of prognosis.
No. What you are telling is everything is correct. What is my question is, has CUP been divided like favorable subsites or favorable prognostic factors, unfavorable prognostic factors?
Supraclavicular is favorable that compared to infraclavicular.
नहीं SCC is better than adeno, इतना नक्की है.
P16
And,
positive is better.
So the CUP has been divided into favorable subsets and unfavorable subsets. Okay. So favorable subsites will be like any poorly differentiated carcinoma, that is extragonadal germ cells and all are with midline distribution is favorable. Okay. Ovary, papillary adenocarcinoma of peritoneal cavity is favorable. Okay. Adenocarcinoma with an axillary occult lymph nodal metastasis is favorable subsite. Squamous cell carcinoma with cervical lymphadenopathy is a favorable subsite. Okay. Isolated inguinal lymph nodes. Okay. That to squamous cell is a favorable. Again, adeno is not. Okay. And poorly differentiated neuroendocrine carcinomas are favorable. Okay. And men blastic bone metastasis with increased PSA. So you can treat them, right? So all favorable will be like where you have some defined treatment. Okay. Where you don't, where you cannot, that will be unfavorable. And patients with single small potentially resectable tumors like in head and neck, you can do cervical lymph nodal dissection. Okay, that is favorable. So these are all favorable subsets. So favorable scenarios. That is one is midline extragonadal germ cell tumors, axillary, then peritoneal cavity, papillary adenocarcinomas, occult axillary lymph node metastasis, inguinal with squamous origin. Okay, PSA elevated bone mets in a man, and single potentially resectable. All this will come under favorable prognostic. Okay. So what will be unfavorable? Now opposite of this. You tell. Now you have listened, no? So tell what is unfavorable.
Inguinal with adeno.
Yes.
And not treated.
Multiple bone mets.
No rise in PSA, multiple bone mets. Yes. Then?
Proven lung mets, proven breast mets.
Yeah, adenocarcinoma to metastatic to liver or any other multiple sites. Okay. Non-papillary ovary cancers. Okay. Or brain mets. Okay, lung mets, brain mets, pleural mets, and multiple bone mets. All are unfavorable. Okay? Right?
Madam, one doubt, madam. If there is nodes in the neck and you told there is ovarian papillary region, then it won't be unknown prime CU, no?
Yeah.
Then it won't be carcinoma of unknown origin.
No. Non-papillary malignant ascites. Okay. If it is papillary, whatever you have found there is nothing in the ovary, but you have found metastasis. Okay. So in the neck, that has come positive for WT1. Okay. That is unknown primary only. No, primary is not there. Okay. What are causes? By the way, I forgot to ask. What are causes of not detecting a primary? What are the theories there? No, what are the theories?
Ma'am, very small primary. There is a vascular regression theory, immunological regression theory, stem cell origin theory,
Okay.
angiogenic incompetence theory.
Or it can be a burnt out primary.
Yes.
Okay. So apart from what all immunological stem cell theories or what all vascular theory, whatever you told, it can be a burnt out primary. So these are the reasons for not detecting a primary. Okay. Yeah. Tell me. So repeat. Somebody has to repeat favorable and unfavorable so that we'll discuss.
Ma'am,
favorable one, ma'am.
One of them favorable, one of them unfavorable.
Extragonadal germ cell tumor, which is midline in location. Men having metastatic bone secondaries from a prostatic primary.
Elevated PSA.
Elevated PSA. Inguinal lymph nodes which are having squamous pathology. Cervical.
Madam, again this prostate came na, again the primary prostate.
प्रोस्टेट में लीजन नहीं है, बस ब्लास्टिक मेट्स है और रेस्ड पीएसए है, तो यू ट्रीट इट एज प्रोस्टेट.
All bone mets are bad except the bone mets which have increased PSA.
Okay.
Got it?
Okay, ma'am.
Yeah.
Cervical lymph nodes having SCC. Pure neuroendocrine carcinoma.
Okay.
Poorly differentiated.
Okay.
Axillary lymph nodes having adenocarcinoma.
You told ovary, yeah? Papillary atrophy of peritoneal cavity.
Yes.
Okay. And last is that where you can operate small lesion.
Small potentially resectable tumors.
One of you tell unfavorable.
And primary.
Am I hearing that the theory? Not a bit. Hello? Okay, we are not able to hear you. Mute person. One of you said unfavorable.
Audible, ma'am?
Yeah.
So, ma'am, inguinal adeno and non-rising PSA bone mets or primary with brain mets, lung mets, liver mets, or
liver, lung, bone mets, brain mets.
Non-papillary peritoneal or ovarian mets.
Then malignant or not resectable. Then hello?
Multiple bone mets, multiple lung mets, multiple brain mets.
Yeah. Okay. So suppose now I'll give you a scenario. Okay. You tell me what all you'll do it in order. Okay. Fine. So first we'll take she's a woman. Okay. Isolated. First thing is she came with isolated axillary lymph node. So tell me which category she comes in, what you want to do in order.
She comes in favorable prognosis, and we want to do a clinical examination of the breast and the axillary. General clinical examination to rule out any other swellings or to rule out any other generalized lymphadenopathy. MRI of the breast and axilla.
Mammography. Physical examination, mammography, MRI. Then you biopsy.
Yes.
What else you want to do on a biopsy?
Try to find out if it is adeno or a squamous. If it is adeno, then further put IHC on it and look for the origin.
What IHC?
The same, cytokeratin first, then after that ER positivity.
It's not squamous. Okay, just it's adeno. Okay, axillary lymphadenopathy. So what is your the IHC you want?
ERPR.
Okay, right. Then
ERPR or
ERPR HER2 new.
Okay.
So now how do you want to treat her? What are the options you will explain her?
Modified radical mastectomy, we can explain her now.
Only one option?
Or axillary lymphadenectomy, isolated eyes.
Ma'am, in this also we are deciding on the basis of ERPR and HER2 status. If it is hormonal positive, then and small lymph node, because it's already nodal positive disease and it's of breast origin. If in case we are suspecting, then we are planning this accordingly, that N positive disease of CA breast, of occult breast disease, in that way only.
Okay. What to do?
So we will do neoadjuvant chemotherapy, and if we are planning BCS, then we will put one clipping over the node or marker in the node in the future. And ALND, then we have three options that we should explain to the patient: only ALND and whole breast RT, or ALND followed by upper quadrantectomy prophylactic in BCS setting, or MRM plus ALND.
In the breast.
But occult lymph node in the axilla with no disease in the breast have three management options. ALND itself or whole breast RT, ALND or along with MRM, ALND along with upper quadrantectomy, and all have comparable results, and no modality is better than other.
Yeah. So you explain all the options, okay? And if you want to give neoadjuvant chemotherapy, if I heard.
Yes, ma'am.
So if it is a triple negative.
If it is TNBC or HER2 positive setting and node, how much large node is also possible, ma'am? Usually,
then neoadjuvant chemotherapy.
Yeah.
Okay. Otherwise, MRM, ALND followed by chemotherapy, hormonal therapy if it's a, and radiation if it's a node positive disease. So mobile.
Let's say hello, ma'am. For occult axillary meds, if you do MRM, like the modified or anything, they say the chances of finding primary in the breast is almost equivalent to 50%.
Not so high. To the extent I remember, it is 20%.
20%.
20%, not 50%. So if it is an N1 disease, treat it as stage 2. Okay, 2A. And if it is an N2 disease, stage 3A. So treat that way. Okay. So if it is, you'll do all the investigations. Okay. If it is positive for breast cancer, you treat it in breast cancer. If it is negative, you don't find anything, what you want to do? Just now we discussed, it's the only lymph node, small disease, with a favorable subsite, then it can be
Treated as a primary.
you can do the axillary lymph node dissection. Okay? Axillary lymph node dissection followed by
Radiation.
yeah, tell them that it may not be there in the breast. Okay, we may not have found it on imaging and all, but as a prophylactic, we will do the breast surgery with lymph node dissection and radiotherapy. Okay, that is about axillary subsite. Suppose patient has presented with papillary adenosine, female.
Of what subsite, ma'am?
Papillary adenosine, you decide. WT1 positive.
Papillary, thyroid and ovary, we have to differentiate.
Level 4 lymph node, papillary adenosine with ascites. But ascites is negative. Your lymph node has come positive. Stage is level 4.
To treat it as primary peritoneal or ovarian origin, which has the same treatment.
What do you want to treat it as? Which?
प्राइमरी पेरिटोनियल करेंगे एंड एक CA-125 भी एज एन एडजंक्ट इन्वेस्टिगेशन करना चाहिए एंड उसके बाद वही NACT रेजिमेंट.
Suppose it is presenting with ascites. Okay. You did not find any lymph node, Avneet, but it presented as ascites. So what's the minimum stage in an ovarian cancer?
1C. 1C.
1C.
ना
1C.
ये हो गया ना ascites में मतलब ascites because of the peritoneal involvement ना. You're not finding anything but it's peritoneal involvement.
It's not spillage, ma. It's 3.
हाँ 3 ना.
1C बोला उसने.
1C is what?
1C is pelvic peritoneum washing में positive है.
No, 1C.
No, scientist रहता है ना C3.
1C, 1, 2 and 3. Intro अगर intro spillage हो तो 1, अगर capillary rupture हो
Washings is positive, not with ascites presentation. Frank ascites is stage 3.
हाँ ना वही ना.
Okay.
Washing positive is 1C, like we said, na. Frank ascites is stage 3, na.
Yeah, stage 3. So, what is your line of treatment? How will you explain? How do you proceed in that case?
Clip the node. Neoadjuvant therapy. अच्छा सिर्फ ascites है. ठीक सिर्फ ascites है.
Then we will send all markers CA-125, CEA, CA-19-9.
125 elevated 1000.
हाँ मैम.
1000.
CA-125.
इमेजिंग करेंगे मैम. इमेजिंग में भी नहीं मिला तो स्टेजिंग लैब एंड प्रोसीड. स्टेजिंग लैब में अगर डिजीज एमनेबल टू रिसेक्शन है, we'll resect, otherwise NACT.
Okay, you do IHC, no? You still don't know. Though it is very rare to have peritoneal mesothelioma, okay? So it can be still one differential diagnosis of a patient who presents with CUP with ascites, okay? So do the markers. If you find it as ovary, treat it as stage 3 ovary. What is the stage 3 ovary treatment?
NACT. But it is from stage 3B.
Madam, one doubt. This case is neck node CUP with ascites.
Not neck node.
No.
Not neck
Ascites.
node. Okay.
Only ascites.
Okay.
Yeah. So tell me, how do you treat it? Is it favorable or unfavorable?
Every
Unfavorable.
adeno is favorable.
Okay, so how do you treat it?
Ma'am, malignant cells in ascites is stage 1C3 only, no, ma'am?
I also remember like that, ma'am.
I just checked NCC and it says 1C3. Malignant cells in ascites or peritoneal washings.
Remember, as peritoneal washings,
Ascites is also 1C3, I think so.
Ascites is also 1C3. 3 is only extrapelvic deposits or lymph nodes.
Yeah, 3 when we have like retroperitoneal nodes or implant peritoneal deposits or liver.
A1, A2, 1, 2, and 3B and 3.
Ma'am, 3A
A is a microscopic. That's why we are doing that cytology. 3B is less than 2 centimeter and 3C is more than 2 centimeter. वो C for lymph nodes था याद नहीं यार.
हाँ मतलब macroscopic peritoneal deposits beyond pelvis or with or without retroperitoneal lymph nodes.
Okay. I remember that peritoneal washing. Anyways, it is okay. How do you want to treat that?
So as if ovary is confirmed, ma'am, then we will do like definitely we'll do imaging, cross sections, CCT, thorax, abdomen, pelvis to see the bulk, and if we know don't see any suspicious lesion on peritoneum or omentum, then we can do staging lab and proceed.
What presented with cervical lymph?
Usually, ma'am, in our setting, what patient comes na that ascites patient of unknown primary types, they have usually poor GC and full blown ascites, and usually patient go for palliative paclicarbo and never come back.
Never like that. Okay, if it is treatable, it's favorable sometimes.
Ma'am, if it is ascites with supraclav lymph node, then it becomes extra abdominal disease stage 4.
Ascites with supraclav. I'm telling only supraclav, no ascites. It came papillary adenosia, which is in favor of ovary, but no ovarian lesion as such in scans.
Then we will do level 4 lymph node dissection and paclicarbo. This is not, I'm not sure.
Metastatic ho gaya na, we will go for
stage 4 ho gaya.
So what is the treatment for stage 4?
NACT.
NACT, yes.
You can call
stage
it as
4 में
you can call it
NACT क्यों देंगे?
No, you can call it as NACT if it is a local small volume disease in ovary. Okay, because you can still treat it with curative intent if it is that's the only site of disease.
Ma'am, in then such a case, we'll still go ahead with a complete staging laparotomy because that is the only site of the disease.
Yes, surgical cytoreduction is mandatory.
Madam, with one doubt, this is 4B now. It is only palliative, na? There is no role of NACT.
That's what I'm telling. So in NACT, you can't call it as NACT. You'll start with chemotherapy, but see the response. If it has disappeared, okay, patient is symptomatically better, but it is like ovary. Okay, treat it like a ovary. Do the cytoreduction how you'll do for a primary ovary. Early stage how you'll do, no, like that you. Okay.
No, and then, one big doubt to me. One big doubt. If I am asked, there is a suspected node in the neck from ovary. What intent should I proceed? Should I go palliative or should I go curative?
See, for your aunt, it is a metastatic. Okay. You will treat it with palliative intent only. Okay. But
okay.
In practice, it is like curative intent. It's a small volume disease. Okay. Ovary still in stage 4, you can do a cytoreduction. Okay. To facilitate enhanced response to chemotherapy. That's it. Nothing else. Okay. Then, okay. So that's about this one. Yeah. Next scenario is squamous cell carcinoma involving cervical lymph nodes. Okay.
Squamous cell carcinoma.
Same biopsy we'll do, ma'am. We'll know if it's adeno or is it squamous. If it is squamous.
But blind is, what do you mean by blind biopsies?
Blind biopsies.
Ma'am, now we don't do it, but earlier we used to take biopsies from the
Base
What
of
are the
tongue.
blind spots? Base of tongue, one.
Base of tongue, fossa of Rosenmuller, posterior pharyngeal wall, and the pyriform fossa, and tonsillar bed, ma'am.
So these are called blind spots. So they used to take random biopsies from that in an attempt to prove the primary. Okay, but now it's no longer done. In era of PET CT, if something is detected, it will be detected. Okay, so HPV, EBV, you told. So it is. Then how do you want to proceed?
Ma'am, now we'll take the patient for examination under anesthesia, and we'll examine for the oral cavity, the oropharynx, nasopharynx, and hypopharynx.
All negative.
Then, ma'am, if it is HPV positive, then we want to do depending on if it is HPV positive and if she has a unilateral adenopathy, then we can do. Sorry,
N1 disease.
HPV positive, ma'am.
Okay, first HPV positive. Tell.
Ma'am, if it is HPV positive N1 disease, then we'll first do unilateral palatine tonsillectomy, send it for frozen section. If it comes out to be negative, then do same side lingual tonsillectomy and send it for frozen section. If it comes out to be negative, then we can do opposite side palatine tonsillectomy.
Patient is not willing for surgery.
Then
any other option to give?
Radiation we can give, ma'am.
Okay. Okay, either surgery.
Ma'am, one question, ma'am. Actually, in Indian scenario, it is like the incidence of oropharyngeal associated HPV positive is very less as compared to Western side. So it is justifiable to do a lingual tonsillectomy, ma'am.
No, the chances of if it is P16 negative, then we don't do tonsillectomy.
It's only positive, then only we do. So why that is done? Why is that done, Avneet? You tell me.
Ma'am, because if it is a P16 positive, then for finding out primary in one of these tonsillectomy goes up to as high as 60%, 60 to 70. Yeah. But in P16 negative, it is hardly 10%.
It's only an attempt, like in blind biopsies, it's only an attempt to find, but because the incidence of finding out primary is more by doing a tonsillectomy, that is considered as one modality of treatment. But with blind biopsies, they did not achieve much. So that's why that modality of treatment was no longer considered. Okay. So if it is N2, N3, what do you want to do?
Ma'am.
Okay. What do you want to do? N1.
Sorry, ma'am. I didn't hear you. If it is
HPV negative, yes. N1 squamous cell carcinoma.
HPV negative squamous cell, then say, ma'am, examination under anesthesia. If under examination under anesthesia with narrowband imaging did not find anything, then we will in N1 disease consider them for giving both
MND
radiation or surgery, both.
Yeah, one surgery.
Surgery level 2, 3, and 4.
Surgery is more preferred. Okay, yes. But if you are not actually, okay. Yes. High stage and 3 ke liye?
Ma'am, then we can, if there is extra nodal extension, then we can consider giving CTRT, or if it is N2 disease, we can consider giving radiation.
N2, N3?
And only B, ma'am. CTRT, multiple lymph nodes is also there, then CTRT is preferred, or N3B.
Only single lymph nodes, then no, RT is okay. Yeah. Then it's
nasopharynx, ma'am, CTRT basically HPV positive with N2 and N3, nasopharyngeal, extranodal extension with HPV negative N2C and NT3. These conditions they suggest according to ASCO guideline, CTRT.
CTRT.
Madam, in first scenario where there was HPV positive, where we are doing this tonsillectomy, in N1 case we have to do neck dissection in case of N1.
Yeah, N1 is advised. If that is the only site of disease, okay, then it can be treated by. There are many cases of CUP, they do neck dissection, okay, because it can be treated well with surgery, is what they believe. Okay, the side effects of RT, okay, long term, like secondary malignancy and all, you'll not have anything left when again after your surgery, if it recurs, you can still have RT as a one modality of treatment, okay, reserve. But if you do give RT, then not every disease that recurs after RT is operable. So choose a modality thinking that it might recur at a later date. Okay. So yeah, neuroendocrine carcinomas.
Neuroendocrine with neck lymph node is also stage 4, na ma'am.
Sorry.
Stage 4, if neuroendocrine origin we are not able to find, then lymph node in the cervical neck will consider stage 4. Then we will start long term lanreotide or somatostatins analog as a treatment.
Can you give chemotherapy if it is suppose it is poor subset?
Poor,
okay, with
for grade
bone,
3
liver.
and grade 3 it is we can give chemo also. For grade 1 and grade 2 it won't be responding to chemo.
What chemo you can give? Neuroendocrine.
Etoposide and what is cisplatin and etoposide.
Captain.
Yeah, captain. Okay. What is that?
Temozolomide.
Yeah, temozolomide. Okay. So yeah. So then suppose it is prostate. It has come as prostate.
Then enzalutamide and PSA.
If PSA elevated, what PSA not elevated?
Okay. Dual blocker they are using for this prostate cancer. 5-phosphodiesterase inhibitor blood and enzalutamide का मैं याद नहीं आ रहा है.
Abiraterone. First they'll start with abiraterone. Okay.
Abiraterone docetaxel combination.
You should always try abiraterone first. Okay. Once you try it will no longer be sensitive to abiraterone. Okay. So then this one you will start them on. But then any study which said dutasteride and all helps or it was negative?
It doesn't help.
Yeah.
Stampede.
Initially, they thought that it will control the rate of growth of prostate cancer.
They finally concluded that if we are giving that patient present with the later stage, stage 3 and stage 4, in spite of being presenting early.
Yeah. So that is the final conclusion. Okay. Then suppose single metastatic site in either lung, brain, lymph nodes, adrenal gland. What do you want to do? Adeno and swamps.
In lung, brain.
Ma'am, visceral mate I think come under the unfavorable, so we'll give the chemotherapy ma'am first.
So single metastasis?
Oligometastatic. SBRT.
Yeah. Oligometastasis, you can consider radiation as well as if it is quite treatable, no other level, no other site of disease. Okay. In some case scenarios, they'll tell, suppose brain, okay, single lesion, suppose lung, single lesion.
SRS.
But SRS can be done as well as surgery can be done.
Surgery can be done.
Okay. So isolated inguinal lymph node from squamous cell. Bad question.
Squamous is good prognosis, you told.
Yeah. So what do you want to do? Isolated inguinal.
Inguinal lymph node dissection.
Dissection. First, rule out
The primary.
melanoma. We should rule out skin cancer and the
Squamous
anal region
cell
cancer.
बोला ना मैम ने.
I'm talking about squamous.
Anal region examination we'll have to do to report anal cancer.
Anything else in men?
Penis.
Penile cancer. Anything in women?
Vulva.
Vulval cancer.
Vulva, vagina,
Cervix.
cervix. Okay.
Lower one third.
Yeah. So how do you want to treat it?
Radical neck dissection, ma'am.
According to primary, inguinal lymph node.
Squamous में can we distinguish which organ it's arise, vulva or anorectum?
I have been there for that only, no?
नहीं वो that's my doubt. In ISC they can discriminate among these organs.
So then for general squamous markers, okay, squamous generally will respond to, if it is the only site of metastasis, you can do the surgery followed by RT. Squamous responds to RT. So that is the blind rule. Okay, but single isolated, you cannot tell it is from penile, it is from vulva, vagina, like that you cannot tell. Okay. All squamous markers are same. Okay, they can tell either it is squamous or adeno. In adeno what? But they cannot tell what in squamous. Okay.
Now I have one doubt, ma'am. In head and neck, we say if there is a squamous level 1, 2, 3 involved, we do the neck dissection. In RT, we do the mucosal radiation bhi dete along with the nodal basing. In case of inguinal lymph node, if you don't find anything or ISC suggests you a particular like vulval cancer or anal cancer, so our treatment plan will be like inguinal lymph node dissection followed by the RT particular to the mucosal area and the nodal basis. The same as in the head and neck, ma'am. The RT should be given to the mucosal side.
You say that you want to give to anal region if it is guinal.
Okay, ma'am.
No. Your doubt is that you will cover radiation field anal region or you
but
cover
ma'am, we are not able to distinguish from where it's arise. Then which mucosal region we will give RT? He's asking that.
It's only to the inguinal region.
Okay.
That too, after you get the histopathology report, extranodal extension, all these things, then you give RT. Otherwise, only surgery will suffice. Okay.
Again, one more question, ma'am.
Lymph node.
Yes, ma'am. In HPV positive, you said if there is a N1 disease like single node, so should we go for radiation first or the surgery first? Because as we teach ki HPV responds better to the radiotherapy, and even guidelines suggest
HPV positive, you will give radiation.
N1.
ASCO guideline I just reading, they said if there is only N1 disease, HPV positive, you can go ahead with the unilateral RT only, ma'am. There is no need to give bilateral.
Yeah, if it is HPV, it is RT. Okay.
Okay.
So now, if it is adenocarcinoma of liver, adenocarcinoma with liver mets.
We'll rule out the colorectal primaries.
Nothing found.
Then according to the isolated or bilateral size less than 3 centimeter, we can do RFA.
Wait. It's I just told it's an adenocarcinoma. Want to do. Don't jump to the treatment. What will you evaluate for? We discussed already.
Breast.
MRI करेंगे.
Ma'am, AFP levels to rule out a primary liver disease.
AFPC.
So you want to do some immunohistochemistry?
Yes.
Yes, ma'am.
So going ahead, that's why. See, when you discuss the treatment scenarios, no, it's not only theoretical. Like you should think, like what next, what next. So I'll do IHC. Same routine things you should follow. Okay, don't jump to treatment. Okay, I'll do CK7. I'll do CK20. I'll do CDX2. Okay, then based on that
Yes.
reports, I will determine what subsite it is. Most probable subsite. So most probable subsite, since it's a metastatic, so I will start off with the chemotherapy. Okay. So if it is metastasis to liver, I would prefer, even if it is, suppose it is from colorectal or GI. So GI, upper GI may also you'll prefer chemotherapy, right? So lower GI also you'll prefer chemotherapy first because it's a metastatic stage 4 disease. Even in colorectal you'll prefer chemotherapy with either FOLFOX and add bevacizumab to it or not. So you'll decide based on what is the IHC. Okay. So
liver only can be primary also, na? Liver only. It can be metastatic or it can be primary liver disease.
So the found primary no longer a CUP. Okay.
Okay.
Can you give empirical chemotherapy? It's not fitting to any of the clinical subgroups. Is there any recommendation that says that you can give empirical chemotherapy? And what will you give it?
If colorectal origin, organ of origin according to IHC, then only they will decide now.
Ma'am, platinum base. Carbo.
Yeah, taxane and platinum based empirical chemotherapies were shown to improve the survival. Okay. So in a patient which is not subcategorized into any of the groups which we discussed. Okay. Pacli carbo can be tried. Okay. Either some drugs can be added like gemcitabine and all. Okay. After taxane and platinum based chemotherapy. Okay. Yeah. Then, but what will be their median survival?
Less than 12 months.
Yeah. So it will be around 6 months, but less than 12 months. Okay. Then, yeah. What else? What are predictors of response to chemotherapy in adenocarcinoma of unknown primary? So how will you see that your chemotherapy is working or?
Grade, ma'am.
On the imaging, we'll see on the basis of the
imaging. Okay, one is imaging. So your the burden of disease has decreased. Then
Clinical, ma'am, symptomatic improvement, size decrease clinically. Yeah.
Then
clinically,
if tumor marker is there, like positive, we can follow that.
Sorry?
If some tumor marker was raised before chemo.
Okay. Then, so the general condition improves. Okay. And it is said that the female gender responds better to empirical chemotherapy rather than male genders. Okay. For reasons unknown. Okay. And there will be improvement in all the lab parameters also. Okay. That will be the indicators for monitoring a response to chemotherapy. It came as poorly differentiated neoplasm, Avneet. What do you want to do?
Ma'am, the IHC markers we'll use first.
Okay. NHL. IHC markers saying it NHL.
Non-Hodgkin lymphoma.
NHL. Good, bad.
Good, huh?
Yeah, it is still because the treatment is known. Okay.
Yes.
Suppose it's poorly differentiated melanoma or sarcoma.
Prognosis wise bad, ma'am, but if we've known the primary, then we can attempt the at least site wise treatment we can give. We won't be giving empirical treatments.
Better than lymphomas, or they do bad than lymphomas?
Bad than lymphomas, ma'am.
So they are considered as bad only, okay,
Yes.
compared to lymphoma category. So what are the other, one we discussed is cytogenetic analysis, okay? One you told, anything else you can, with respect to hematological tumors, anything else you can do?
Bone marrow examination.
Bone marrow, yes. That is cytogenetic analysis, okay? Multiple myeloma, benzone proteins.
Yes,
One of the
electrophoresis.
Electrophoresis. Electron microscopy. What? Electron microscopy is for
LCH, Langerhans self.
to karyotyping. All that hematological malignancies only, you can see through electron microscopy. How you do this analysis, no, cytogenetic analysis. So few this one can be seen on electron microscopy also. Okay. So, yeah. So how do you follow up?
Ma'am, we'll after we've completed the therapy, if you're giving chemo radiation on chemotherapy, we'll follow up the patient every 3 monthly for if there is any primary that has come up, or if there is a recurrence with the clinic.
Every three monthly for how long?
1 year at least, ma'am.
Hey,
2 years.
what does recommend?
2 years.
2 years, then 6 monthly for 5 years.
First 3 years in case of new is first 3 years 3 monthly, then 6 monthly for next 2 years, and like yearly thereafter. Okay. Okay. And then anything else?
Madam, I got confused again. In N1 disease, HPV positive, in HPV negative. Kindly explain. And as we discussed, in HPV positive, we have to do tonsillectomy and field of radiation. As earlier we discussed, we have to address N1 in case of HPV positive. Kindly, but he is telling ESCO is telling radiation. Kindly, confusion clear kar dijiye. Because I read previously, if it is N1, it is resectable tumors. We can resect it. We can give an option of resection of N1 disease in both scenario. But I think I need some more clarification.
So tonsillectomy is an attempt to find out the primary. Okay, it is an investigative modality rather than treatment modality. Okay.
It is only for HPV positive, madam.
Yeah, HPV positive. Okay.
Okay.
So
okay.
HPV positive, low burden disease, that is N1. Okay. So generally all the HPV positive cases, they'll respond well to radiation. Okay. You can give the options of radiation versus surgery. Okay. In case of N1 disease, which is HPV positives, radiation and surgical, this one have equal treatment effect. Whereas in HPV negative, okay, surgery versus radiation, surgery is better than radiation. Okay, both the treatment options are possible. Even in N1 disease, RT and surgery are possible, but RT has more effect in a HPV positive case. So if it is a HPV positive case, you can give them option of RT against surgery. Okay.
Okay. In case of N3 disease, we have to still address the tonsil. In case of HPV positive, N3 disease.
That's what I'm telling, that it's a modality to find out the primary. It's not the treatment. You got it?
In HPV positive, any case we have to address it.
You have to do tonsillectomy.
Okay. Not in HPV negative.
Not in HPV negative.
Thank you.
So, anything else? Okay, electron microscopy will be for lymphomas and certain to differentiate some adeno from squamous also. Okay, and then what else? Yeah, can you tell me some translocations cytogenetics mein?
Ma'am,
Sorry?
common we have discussed previously, ma'am, like Ewing, clear cell, liposarcoma. Hello?
Ewing is what? Translocation?
1122.
1122. What is?
DSCRT is also 1122.
No, Ewing is 1222, no, ma'am?
No, Ewing is 1122.
Clear cell.
What is synovial?
X18, ma'am.
X18.
X17 is alveolar.
Yeah. And translocation in alveolar is 113 or 213?
213.
Yeah. Burkitt lymphoma?
1121, ma'am.
No. What is Philadelphia chromosome translocation?
ABL.
BCR.
What is the one in that? 9?
922 translocation.
922. And Burkitt says 814. Okay.
814, ma'am, yes.
So, and what about germ cell tumors? Which chromosome?
12P.
12P, ma'am.
Yeah. Retinoblastoma?
30.
3.
RBL gene.
And yeah, that are more common translocations. So, anything else you people want to know?
Madam, the de-escalation oropharynx, how to assimilate in simple words?
De-escalate trial,
how there are confusion हो रहा है मुझे, how to tell de-escalation in oropharynx? भूल गया.
De-escalation in oropharynx.
We have de-escalate RT, we de-escalate CT, but भूल गया अभी मुझे अचानक से याद आया. Anybody can how to de-escalation में क्या?
They tried 3 things. They tried to.
Has already failed.
Did
Cetuximab already failed. We cannot use cisplatin.
Yeah, one is
So they tried to replace cetuximab in place of cisplatin. That has failed. They tried to decrease the RT dose. That has somehow worked. They tried to do cisplatin 3 weekly versus weekly. So that has also failed, and there is no strong data for that. There is just an abstract that had shown some evidence, but that has also not shown any. There is no proper study that has shown. And then they tried doing a risk-adjusted surgery. That has also failed. These were the 4.
And this orator 1 and orator 2 come in.
So there was just one modality that worked. That was decreasing the RT dose. That has worked.
I think in HPV only, na?
HPV only.
Yes,
use of proton also.
Yeah, in modalities of RT they have taken and
proton instead of photon.
I don't remember exactly what de-escalate trial told. You people will know better. Recent.
There is a Mehana trial which replaced the cisplatin with the cetuximab, but they found that it is a non-inferior. Cisplatin with RT is better than cetuximab with RT. Though the toxicity is same, but the cisplatin plus RT is better than cetuximab. And second one, neoadjuvant CT followed by the decreased doses of radiation, as Avneet has explained already now.
3 weekly cisplatin is only, that is standard dose. Then they tried doing tours for everybody, and the patients who actually needed radiation post tours, they tried to give radiation for those. This was one of the modalities that they tried. So they found better survival only in the HPV positive. No.
In relation to RT with cisplatin and RT with cetuximab also they tried, I think, no?
Yeah. Cetuximab was not good. Okay, thank you, ma'am. Thanks a lot for giving time.
I think we discussed more or less everything.
Ma'am, one last silly question, ma'am. This is the regression is spontaneous regression of the tumor associated HPV or oropharynx. So I don't getting the concept behind that one. What will be the reason, ma'am? Like even if melanoma, we have the spontaneous regression.
That is like burnt out primary.
Burnout kind of.
I think it is related to that how much immunogenic the tumor is. Like we have MMR, MSI. The more lymphocytes, they are prone to get spontaneous regression because of more immunogenicity and no need for escalation of treatment.
Yes, sir.
That theory is all they have proposed, no? That immunogenic clonal selection theory.
Stem cell theory also.
Stem cell theory. All these things might contribute to a non-detection of the primary. That's it.
Thank you, ma'am. Thank you very much.
Okay.